So before we launch into our second connective tissue lecture, let's talk about a couple of important things. Why can't a pirate play cards? They're dishonest. Okay? Not all pirates are dishonest, but probably more of them. In the profession, I think it goes hand in hand. What's another idea? Why can't a pirate play cards? He's hooked. Only has one hand. Because he's sitting on the deck. Alright, how about this one? What kind of animal would you never play video games with?
A cheetah.
A cheetah. There you go. Of course, my kids said video games. I love that. Okay, so here's how this is going to work. This is the new material. So just like I promised on that last exam, this material we didn't get to, so we didn't cover it on the exam. But this will be game on for the exam. Okay, because we're not going to skip it. We're going to work diligently to get caught up, and I think we'll get caught up in the skin. Between this week and next week, we'll be back on track. All right? So we got to finish out connective tissue. This is our second lecture of connective tissue. And we're going to talk a little about the different types of connective tissue. We're going to go through that, and we're going to talk about different types of muscle. And then we'll finish it out with nervous tissue. So, in the different types of connective tissue, we have sort of the connective tissue proper, or what we call the largest group of connective tissue. Under this category of proper, we would see both loose and dense types of connective tissue. We'll see everything except for bone, blood, and cartilage. And we're going to see that they're made up of fibroblasts, or what we call fibrocytes. So the word cyte is just another word that we use for a mature cell. So fibroblast would be a developing cell, and a fibrocyte or an osteocyte would be a bone cell. So if we look at the different types of loose connective tissue, the first one, and we talked about this one already, but we're going to go in a little bit more detail. This is areolar connective tissue. Here's a picture of what that looks like. Okay, this was talked about in our last lectures, but now we're kind of finishing out the details. Loose connective tissue, areolar style, is a higher gel component than it is of proteins. And if it's higher gel component, what does that do? More cushion, okay? More insulation, more shock absorbing characteristics. That gel component has a compound in it called what? What was that bottle brush looking structure that was within the gel component that we talked about? I don't remember, that was the last exam. Proteoglycans. Okay, remember sugar-coated proteins, proteoglycans, they have a slight negative charge. They attract a positive sodium. Sodium's high outside the cell. When that sodium binds, water follows. That's what hydrates the tissue. We find these primarily under the epithelial layer. We see them around blood vessels. And it's a nice site for diffusion because it's a nice open framework. It allows for white blood cells, or leukocytes, to migrate out of the vasculature and into the surrounding tissue. So areolar connective tissue binds stuff together. You find it kind of underneath the top layer of the skin. You find it around blood vessels. If you've ever had the opportunity to be in a surgical case where they're dissecting down, okay, you see tremendous amounts of areolar tissue as you cut into layers of extracellular matrix tissue. It's kind of stringy, it opens up, it's very loose in its arrangement, and it's very, very moist, it's full of fluid. Adipocytes, still under the category of connective tissue. Adipocytes, or what we call adipocytes, depending upon how you want to pronounce it. They are originally derived from fibroblasts, developmentally, and the central dogma is they don't necessarily divide. Okay? You manufacture new ones as you need them. They're found primarily or predominantly in subcutaneous tissue. As an organism, we have a lot of subcutaneous fat. There's a lot of other organisms that don't store subcutaneous fat quite like what we do. If you see a lot of other mammals that are very furry, they don't need their subcutaneous fat like what we do because we don't have a furry coat. Okay, so we use this subcutaneous fat as our insulator and to retain heat. It stores neutral fats, these adipocytes or these adipocytes. It's a very rich supply of blood that goes to adipocytes because they're storing energy and they're storing nutrition. So you actually have to have a roadway to get the nutrition there. And then when you need it, you need to have a roadway to get it away. They're considered to be biological silos. You know, if you ever drive in the Midwest and you're kind of driving on a road and you look out and you see a giant silo, well, if there's not a road going to the silo, it's sort of pointless. Okay, so if you're going to storehouse energy here, you need to have a way to drop off energy to it and take energy away from it. So they're very, very vascularized tissue.
I have a question. When someone who's really obese loses weight, do some of their adipocytes die? Or do the adipocytes just shrink and atrophy? Or do they die?
It's a good question. Most oftentimes, if someone who's very, very overweight loses a lot of weight, the number of adipocytes doesn't typically change much.
Oh, so they don't die?
They basically lose their content, and then you save them for later in case you want to store energy again.
Okay.
The best way to get rid, or not the best way, but a way to get rid of them is actually to surgically remove them, or liposuction them away, which leads to this bottom bullet point. So how is stem cells related to liposuction? Well, so stem cells are found within adipose tissue. We see adult sources of stem cells in adipose tissue, and we call them adult or adipose-derived stem cells. And there's actually a big push within the medical community now to look at sources of stem cells and where can you find them. And we've been, for years, harvesting or farming bone marrow-derived stem cells. Well, bone marrow-derived stem cells in all of us, we'll talk about this in subsequent lectures, but the hematopoietic bone marrow tissue, that's a fancy word that says the tissue that gives rise to new white blood cells and red blood cells, it actually starts to shrink in size as you get older. And so by the time that we're this age, okay, I put myself in the category of all of you, or you're in the category of me, however you look at it, all of the long bones in our body don't necessarily have marrow tissue that's active. It's actually primarily in the femoral head region of the pelvic girdle. And so if we're going to do a bone marrow transplant and we're a perfect match, and I was donating to you, it would be a large needle bore into the hip to get into the femoral head. Okay? And so we've been searching for other sources because there's limited sources, there's limited matches, and the donation is actually almost as uncomfortable, or in some cases more uncomfortable than the recipient receiving it. So we look at circulating blood cells. We have circulating stem cells. Well, in the fat, and we actually look at this in my lab, we play around with fat. We love fat. A lot of stem cells in it. And we take adipose liposuction fat, we harvest the stem cells from it, and we can ID it for that particular patient. And it doesn't matter how thin or how thick you are, you have plenty of subcutaneous fat that we could achieve for therapeutic uses. We literally only need about 60 cc's, which is a conical tube about like that, full of subcutaneous fat. Okay, so even in the thinnest individual, you can get that. And then it's a perfect match, and you can store it and bank it. Okay, so just an interesting fact about fat that we're starting to look at in a very different light these days is there could be some very large therapeutic potentials within subcutaneous fat. Okay, still in the realm of connective tissue, we have reticular style connective tissue. It is areolar-like, meaning that it's open, okay, but it has a fine meshwork of collagen fibrils that looks a little different than the areolar type of connective tissue. This is usually found in lymph nodes or lymphoid tissues. It acts as a really nice filter, or the word here that's shown is sieve. So as things flow through the lymph organ, it's collected and caught. Okay? The lymph tissue is a very important tissue for immune function because as it acts as a filter catches things, it's going to catch antigens and bacteria. And as it catches them, it houses them there in those lymph organs. You'll learn more about the lymph circulation next semester in 202, but you already know a little bit about it, right? How many of you had a sore throat recently, like in the last year? Okay? What happens to the side of your neck? It gets really swollen, right? Because you have large lymph nodes on the side of your neck. And then sometimes you have experienced that, and soon after, you get a really sore armpit. Have you ever had a sore armpit after a cold? Okay? There's lymph tissue in your armpits, auxiliary lymph nodes, and they can be sort of like you put your deodorant on and it hurts. Okay, it's the same type of organ, and they're located in all these different junctions in the body. They're in the groin, okay, they're all throughout the legs and the arms. Tonsils, how many of you had your tonsils removed? That's lymphoid tissue. It's collected bacteria, and the bacteria won out, and that infection was getting aggravated, so we just came in and took out the organ itself. And the reason you can do that is you have all these other backup lymph organs with reticular-like connective tissue that's like a catch, like a filter. Okay? Dense regular connective tissue. So dense regular connective tissue is oftentimes misdiagnosed or misidentified as being smooth muscle cell or smooth muscle. But the difference here is smooth muscle has far more nuclei, right? Because muscle tissue is not a connective tissue, right? You have epithelium, connective tissue, you have muscle, and you have nervous. So we're in our second category. We talked about epithelial tissue, and we introduced connective tissue. Now we're finishing out connective tissue. Then we'll move on to muscle, and lastly we'll talk about nervous tissue. But this does look like smooth muscle, but the difference is, look at how few nuclei that are here. Remember, connective tissue is cellular poor and matrix rich. Okay, so the dark purple lines or blobs are nuclei. If this was smooth muscle, you would see many more purple dots on the screen. And I'll show you an example in a few slides when we get to the muscle section. Well, the dense regular connective tissue, you can kind of see it's organized in this fashion, like the plane of wood. If you're looking at a piece of wood and you're following the grain, it would be going in this direction. So it has a high collagen content. It's very strong. Tendons and ligaments are made up of dense regular connective tissue. It resists stretching in this direction, in one plane, the plane that these things are organized in. You can see that it's very densely packed. This is one of our exceptions to the rule because it's poorly vascularized. The other ones that we came from are very well vascularized. This one's poorly vascularized. The other thing that's problematic from a development standpoint or from a building standpoint is it's strong in this direction, but it's really weak in this direction. Because this is the direction of the planes, or the grain of the wood, if you will. And so if you tug on it like this, and most of these ligaments and these tendons, like for example, the ligaments in the knee, they're going to come down in this direction. So as long as you operate in this plane, you're doing just fine. But the moment you operate in this plane, right, you're tugging on it in a different direction, and that's actually where it tears. So you have an ACL tear. There's an ACL and a PCL, an anterior cruciate ligament, and a posterior cruciate ligament, one in front, one in the back, and they form a cross. That's what the word cruciate means. So they form this little cross, and as you turn and do a lateral cut one direction or the other, you actually have the opportunity to tear either one or both of those ligaments because they're not strong in that side-to-side direction. Okay? If we look at the other version, which if you have the opportunity to design a new knee, right, this might be the type of connective tissue that you decide to use. Because this is called dense irregular connective tissue. For all of those that like the word irregular, you're going to be excited about this. Okay? So you can see the arrangement of the fibers are more random. You see how they're all over the place? They don't line up in one plane. And so if that's the case, there's still collagen here, but you have tensions in all sorts of different directions. And so you have strength in all sorts of different directions. So where do you find this? You find dense, irregular connective tissue around a lot of joint capsules, around the organs themselves. You find it around the aorta. And you also find it underneath the skin. It's underneath the top layer of the skin and the dermal layer. And so that's why our skin is super strong. If you tug on it, okay, or if you pull on it or push on it, it doesn't easily tear and rupture because it has dense, irregular connective tissue. So you have these tensions in all different planes because of the way that it's organized. So these are two perfect examples of how structure gives rise to the function. This is a much stronger connective tissue than its regular counterpart. Favors the irregularity, right? All right. Staying true to connective tissue and staying true to some other examples of avascular is cartilage. So there's no blood supply and there's no nerves. We have a perichondrium. The perichondrium is the layer that surrounds the cartilage. The perichondrium is dense, irregular connective tissue. So even though the cartilage is regular connective tissue, the surrounding material around it is the dense, irregular. So they're not completely vulnerable because they have a capsule of irregular tissue around them. But if you stress it too much, it doesn't have that characteristic all the way through. So that layer that surrounds it of irregular connective tissue surrounds the cartilage of a developing bone. So you're going to see later in the semester, as we move on and we talk about bone development and where bone comes from, typically you start out with a cartilaginous material and then you ossify it or you harden it. And the wrapping around that cartilaginous plate before it becomes bone is dense, irregular connective tissue, otherwise known as perichondrium. Question and then this question.
Okay, I have a question. I'm looking in the lab manual and the description you just gave of dense, irregular, and dense, regular connective tissue. I get the impression dense, regular connective tissue, since it's only going in one direction, that would be good for stuff like joints, like being around joints and things like that, because you have to be able to move your body in certain, like in only one certain direction. You know what I mean? Like,
yep.
Yeah. Like there's only certain ways you can move your joints.
That's true, and you do see it there. So there only are a few joints that actually move in multiple planes. They're more uncommon. Okay, like your shoulder joint moves in multiple planes. There are still ligaments and tendons there, but they're strapped in all sorts of different directions. So when you use dense, regular connective tissue around the shoulder, which is a synovial joint, you can do all sorts of different motions with it. You don't have one ligament, to your point. You have a ligament that comes this direction, you have a ligament that comes that direction, because you need to stabilize it in all these different areas.
The dense, regular connective is mostly found like around joints.
Joints, that's correct. Yep.
Okay, glad I figured that out.
Tendons and ligaments. Tendons and ligaments, yes. Meniscal tissue is connective tissue. Specifically, it's this, cartilage. Cartilaginous tissue makes up the menisci. Okay? So you can see here, you're welcome, you can see here that this is cartilage, right? It's cellularized, but look at the ratio of cells to matrix around it, right? More matrix, fewer cells. Remember that? So this is definitely still in the category of connective tissue. And these little cells that we'll look at, they hollow out this little space, this little lacunae, and that's where they actually sit. So if we look at the different types of cartilage, we see that we're going to cover three main types of cartilage. Well, the first one up on our list is hyaline cartilage. And some pictures of hyaline-like cartilage. It's very glassy and white-looking, glistening under dissection. It is the most abundant cartilage that you find in the body. You find it wrapping around the trachea, the tip of the nose, the costal cartilage of the ribs and the sternum, and at the end of many long bones. It has a content of about 40% collagen. If you look at the next one, which is elastic, this one actually has sort of a stretchy capability because of these elastic fibers that are found within it. In the beginning of the semester, I was talking about stains. Right? There's a very commonly used stain here. This is a Van Giesen stain. You don't necessarily need to remember that name. but this stain usually is a dark purple or a very dark black. Okay? And you can kind of appreciate where these red arrows are pointing to these black lines. This one has a little squiggly component at the bottom, and then it's more straight at the top. Those are those elastic fibers. Okay? So usually when you look at elastin, it will be a dark colored stain, just because primarily it's using this Von Giesen stain. The last one is fibrocartilage. Fibrocartilage is a little less firm than the Highland style. It is much more compressible. Okay, so it has the ability to receive greater forces. And it tends to be a linker or a connector between hyaline and dense regular connective tissue. So you use it when you need the ability to handle compression and have strength at the same time. So you find these at the menisci in the knees that was asked about earlier. You find them in between the vertebrae in the vertebral column. And you also find fibrocartilage type at the level of the pubic symphysis. Okay, that's where the two os coxa come together at the level of the pelvis on the very inferior portion. So it has this wavy parallel line appearance to it, okay, organized in a very regular shape. All right, we're still in connective tissue. So we have tendons, we have ligaments, we have our areolar type, we have our cartilage, and now we actually have bone. Bone is a type of connective tissue. We're going to get into bone in this next unit. So it's very relevant. We've got two different main types of bone, and each of those main types of bone have three names that you're going to find in the literature, just to make it clear or confusing. Okay? So cancellous bone. Cancellous bone or trabeculated bone, or what we call spongy bone. Three different names for the same type of bone. So depending upon which version of the textbook and which possibly even publisher you bought, you may see any one of these three terms referring to the same type of bone. And the secret here is it gets its name spongy because under microarchitecture it has all these open spaces. Okay? And the stuff that's bone that comes in between the open space are what we call trabeculated. That's why it's called trabeculated bone. Cancellous bone is a word that refers to the content of the bone. So, one type, osseous, cortical, or compact bone. This is the second type. This one doesn't have the same appearance. It doesn't have the same trabeculated appearance. This is a picture of what type of bone prep?
Osseous.
Osseous bone. This bone is showing the osteon, or the unit of bone. Down the middle of it is black dot, which is actually a column, right? That's actually the central canal. That's where the main nutrition flows through. We're going to talk more about this architecture later in the semester in this unit in just a few weeks. The bone itself has bone mineral known as hydroxyapatite. This is a mineral form of calcium, calcium apatite. It's abbreviated many times in the literature as HA. And there's a unique blood vessel arrangement of bone. Bone has this channel-like system. Okay? It's almost like if you took a bundle of pencils and you strapped them together with a rubber band, and then you stood them on this podium and you looked up like this. This would be the organizations of the osteons. And the architecture of the blood vessels follows that same parallel fashion. Then you have these diving out, right, perpendicular lines that go and perfuse the bone. So when you cut through bone, it bleeds like crazy. We'll get into why there's such a prevalent vasculature in bone when we start talking about bone in a couple of weeks. But if you're ever in an orthopedic case and you have the opportunity to see them drill into bone or cut bone, it bleeds like crazy. And that's actually part of the reason that it heals so well. Most of you that have had bone breaks, usually within an 8-week period of time, the bone is healed. Okay, because it's very well vascularized. So, the osteon, I just went over that. There's these connections between one side to the other, which are called canaliculi. and they actually connect one lacunae to another. And we'll talk more about that microarchitecture. If we look at cancellous bone, okay, we were looking previously at osseous bone. Now if we look at cancellous bone, this is trabeculated or spongy bone. There's two other names for it. The trabeculae are labeled in the T, and these are like little spires or spicules of bone, hard areas. And from one trabeculae to another, in between them is open space. That open space, if you took out all the cells, would look like a vacant sponge. Okay? And that open space physiologically houses marrow. And the marrow itself is dense with adipocytes. Adipocytes are fat tissue. And that's what's labeled by the A. So in between these two spicules or spires of bone, the trabeculae, you actually have marrow, and that marrow is serving a physiologic function.
Wait, are you trying to say that bone actually stores fat?
Mm-hmm.
Oh.
Yep.
Then how come when people get fat, their bones don't seem to get any bigger, they just seem to get...
Well, there's a limit to the size of bones, the density the bones can create. So, I mean, as we put on weight, the bones will densify, they will become heavier to be able to support that additional weight. But there's a limit to which, I mean, you can see in the clinical literature, right? Stay with me, guys. You know, they have these lap band procedures, right? They have procedures where they'll go in and they'll influence the absorption of nutrition in the gut. In the GI tract in certain phases to prevent the number of calories from coming in. And those are done in many cases when patients have reached that sort of limit and it's becoming harmful. Like they're not able to move now. And they might break something if they actually try to leave the house. Okay, so there is a limit, a maximum that the bone can actually handle. But it does a pretty good job under most conditions. Okay, this is another type of prep. This is called a decalcified bone prep. Okay, and you've seen this in lab, and the reason that it's decalcified is that calcium is very difficult to cut through. You have to cut a very thin a very thick section if you don't decalcify it. Then you grind it down on like a belt sander type of thing, okay, and then you actually polish it. Well, if you decalcify it first, you can decalcify bone with lots of different things, but it's a vinegar-like solution, okay. And you've probably done this experiment. Maybe some of you have done this experiment in grade school. There's a lot of calcium in an eggshell. If you put a raw egg or a hard-boiled egg into a glass of vinegar for a couple of days, what happens to the calcium? It leaches out, and the eggshell is rubbery. Okay? So this is the same type of procedure with a vinegar-like solution that actually decalcifies the prep. That allows us to make these sections very, very thin, and now we get to see cells. And the cells that we see are threefold, three different types of cells in bone. First off, we have our osteoblast. This is our osteoblast. Okay? Osteoblast is a bone-building cell. The way I remember that is BB, osteoblast, bone building. Then we have an osteoclast over here. It's multinucleated. That's why this one's only single nuclei. That's how you know this is an osteoclast. It's usually much bigger, and it has many nuclei. And an osteoclast chews up bone. It dissolves bone. Well, why would I want to do that? You're doing that right now. Your bone is constantly changing and turning over. We'll talk more about that in a couple of weeks. But the osteoclasts are chewing away this front. You see this little cavity right here? And these guys over here are laying down new bone. So it's like two little siblings. This one's actually making a mess in the room, and this one's actually cleaning it up. Okay? And then the osteocytes are like the sibling that just stay out of the way. These are mature cells of bone that are living within their lacunae, and they're resident. They're quiescent. They're not building or chewing up. They're just quiescent. We'll talk about it more, but you only see the three different types of bone cells in this type of a prep of compact bone, decalcified bone. Okay, blood. Blood is a connective tissue. I'll say it again. Blood is a type of connective tissue. Now, the matrix itself you only see when the blood clots. But if you look, and you'll see this in 202 much more apparently, if you look at clotted blood under a microscope, you can absolutely see the matrix fibers. Okay? It's full of fibrinogen, or fibrin, and it's full of all sorts of other types of fibers, like what we've seen in a lot of these different connective tissues. And there's cells that exist in there. There's white blood cells, there's platelets, and there's red blood cells. So, from a classification standpoint, this is about all we're going to do to talk about blood, and you're going to cover it again in 202. So that's epithelial tissue, last unit. Started connective tissue, finished it up now. Now we need to talk about the third and the fourth tissue type. Muscle tissue. So what do muscles do? Well, their main role is to contract or to shorten. They have a specialized structure that allows them to function in this way. And we'll talk in depth about muscle. And right now we're just kind of introducing the general broad categories. These are cell-rich, and they're very well vascularized. Okay, we're in a totally different category now. They are elongated cells, but they are typical cells. They're not really any different than a cell that you would find anywhere else in the body. They have fibers within them, and they have cytoskeleton filaments that hold the architecture of the cell in its native conformation. We have three types: skeletal, smooth, and cardiac. So first up is skeletal muscle. This is under what we call voluntary control, primarily. It attaches bone to bones through the use of tendons. At the end of the muscle, there's a tendon organ that inserts into the bone that it's actually attaching to. They're elongated and they're multinucleated cells that we see. It's not a typical cell that's round or even oval. It's elongated, very, very, very thin. And they're striated. They're striated because of the pattern of the cytoskeletal filaments known as actin and myosin. And because of the way that they're organized, it has this very dark light appearance to it. And so that's what you see microscopically, is this pattern. Very similar to skeletal muscle is cardiac muscle, but this is under involuntary control. Right? You're not sitting here going beep, 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 beep. Oh crap, beep, beep. I forgot to. So you don't have to think about contracting cardiac muscle under involuntary control. It's branched instead of unbranched like we saw with skeletal muscle. They are uninucleated, meaning they only have one nucleus. They're still striated because they have the same type of actin and myosin architecture inside the cell. So we still see the striated appearance. You know, what am I talking about with the striations? Do you see these little bands right here? They're going light and dark. That's the striations that I'm talking about. Now, one thing that's unique about these guys is they have these structures known as intercalated discs. These are made up of proteins, and these proteins connect one cell to the other. We introduced this concept in the very beginning of the semester. We're talking about the purpose of proteins. Remember, cell-to-cell communication. That's an example here. Intercalated discs are transmembrane proteins that connect one myocyte, cardiac myocyte, to the adjacent cardiac myocyte line. Well, when this one is sending a signal to contract, then it tells the neighboring one it's your turn. It's like kind of, you ever been to a stadium and they're doing the wave?
Oh, yeah.
Yeah. And you know that it's coming, you see it coming, right? And the people next to you stand up, you know, we should do it right now. You guys ready? Let's start over here and we're going to go the way this way. Okay, ready? One. And then there's always some punk up front that's like, so, like you don't know what to do, right? Ready? 1, 2, 3. Look at that. That was like intercalated discs. That was perfect. We had notebooks flying. So the way that you guys knew that was happening is because you're watching. But if you didn't have the visible reaction, and you could still do it if we're all holding hands, but then that violates personal space. We don't do that. Okay? Because you could do that. You could do that with your arms, and we could just do the wave. So that's just like an intercalated disc. They're connecting the electric signal from one cell to another. The only ones that have it are cardiac muscle. Our third category of muscle, smooth. Smooth muscle under involuntary control. found in the internal organs, they're very slow, sustained contractions. Unlike cardiac and skeletal muscle, they're very rapid and fast. Smooth muscle is much slower. And it makes sense. Why would you design it to be slower for digestion? Right? You have to take your time to get all the nutrients out. You don't want to eat something and then, 2 seconds later, it's, coming out. So you want to eat it, process it slowly, digest it, and absorb all the nutrition. Okay? If you want to run away from a bear, you don't want smooth muscle in your limbs. Right? You want to be able to run fast. And same with the cardiac muscle. I mean, contractions, we did that little exercise. Remember the pulse rate that we did at the beginning of the semester? No matter what the number was, it was actually, pretty much around a beat per second. You don't want it to be 10% of that. You wouldn't be able to perfuse the organism appropriately. So these guys are slow, sustained contractions. They're uninucleated. There's no visible striations. We still have actin and myosin present in smooth muscle. It's just organized very differently, so you don't see that banding pattern. We'll talk more about that later.
When it's uninucleated, but there's a lot of nuclei.
Yeah, so uninucleated means one cell has one nucleus.
Okay.
Multinucleated means that one cell can have many nuclei. That's what that designation means. So you're right. This one has lots of nuclei, but every time you're seeing a nucleus, that's a new cell. If I compare this, thank you for bringing that, because if I compare this back to dense, regular connective tissue, remember that? If you go back, don't get sick. See? This one has far fewer nuclei in the tissue itself. That's a connective tissue. And smooth muscle is a muscle tissue. Okay? So, even though it looks like there's many, many nuclei, every cell itself has one nucleus. Fusiform is a word that means like spindle-like. So it's going to be kind of thin on the ends, and then it kind of, thin on the edges, fattens in the middle, and then thin on the bottom. Or this way. Fusiform. Spindle-like. Okay, our last type of tissue in this lecture is nervous tissue. Nervous tissue is rather interesting. This is a cell. This big purple with all these branches, that's a single cell, and that's the nucleus inside that single cell, and that's a neuron. Its role is to send and receive information. It has like receptors or receivers known as dendrites. It has a main cell body known as a soma, and then has an axon that sends the signal out somewhere else. There's a second type of tissue, or cell, in nervous tissue. We have our conducting cell, which is the neuron. It is transmitting electricity. And then we have these support cells, known as glial cells, that actually don't transmit electricity. They don't send an action potential. They don't tell a muscle to fire. They do everything to support the neuron. So they're smaller. They're all of these little purple dots on the periphery. They're more numerous, and there's multiple types that we'll get into later. But their idea is to do things like either support it structurally or to support the neuron with nutrition. So that actually concludes and wraps up our tissues and histology segment. And then we went through, just to recap, we went through epithelium, connective tissue, and then we stopped at connective tissue and finished it today. And then we went on to muscle tissue, and lastly, nervous tissue. Okay? Questions?
Is there any biological